House Appropriations Subcommittee on Health and Human Services will come to order. Clerk, please take the roll.
Chair Morse.
Here.
Vice Chair Martis. Here. Representative Hood. Representative Brabeck. Here. Representative O'Neill. Representative Purry. Representative Farhat. Representative Price.
Here.
Representative Skaggs.
Here.
Representative Snyder.
Here.
Vice Chair Green.
Present.
Representative Bolin.
Here.
Representative Meerman. Representative Kuhn.
Here.
Representative Steele.
Here.
Madam Chair, you have a quorum.
Thank you, Clerk. Representative Price moves to approve the minutes of March 8th, 2023. Hearing no objection, the minutes are approved. Welcome, everybody. Today, we will have stakeholder presentations on community mental health and Michigan Health and Hospital Association. We also will have the Department of Health and Human Services present on the fiscal year 2023-24 executive recommendation for our state hospital administration. So today, right now, I'd like to call up Jeff Patton, Chip Johnston, and Bill Ward. Oh. Actually, I think Jeff Patton is on Zoom.
Good morning.
There he is.
Can you hear me? Good morning.
Yes, thank you, Jeff. Jeff is the CEO of Integrated Services of Kalamazoo, and please take it away.
Well, thank you very much, and thank you for the opportunity to present this morning on community mental health. Certainly, I want to thank you, Representative Morse, for all the hard work that you do in representing our district, which covers Texas Township in Kalamazoo County. And of course, chairing this very important Appropriations Committee, subcommittee for the Michigan Department of Health and Human Services. I have submitted to you a larger presentation, which I don't have time to go through, and I'm sure that you don't want me to go through this morning because it is pretty lengthy. But essentially what I have provided you is some areas of where the Michigan public mental health system have evolved over the last 50 or more years. And part of that evolution, and I'll just give you some of the high points of what I have submitted to you. The evolution of the public mental health system, the estimates of unmet needs for adults with serious mental illnesses, children and youth with serious emotional disturbances, people with intellectual and developmental disabilities, and also persons with substance use disorders. We know that overall access to behavioral health care in Michigan, over the years, the evolution of Michigan's public mental health system, and then the institutional era. And I have been in this system for 40 years, and part of those years was with the Michigan Department of Mental Health, which became the Michigan Department of Community Health and now referred to as the Michigan Department of Health and Human Services. And over the last, I'm in my 22nd year as Chief Executive Officer of Integrated Services of Kalamazoo, which is the public community mental health services program authority in Kalamazoo County. Over the years, there has been momentum towards change, including President John F. Kennedy's signing of the 1963 Community Mental Health Centers Act. Then in April 1963, when the Michigan legislature passed Public Act 54, which created county-sponsored or county-created community mental health services programs. Then the establishment of federal community mental health center grants and Michigan's funding support for community mental health services programs started back in the 50s. Then there was a momentum for change that was spurred on by the notion that some individuals with serious mental illnesses might require episodic care during acute phases of illness. But we've also recognized that these individuals could be released back into the community. And I don't like that word release because we don't use that term anymore. But individuals that could be in community settings and provided local aftercare programs as soon as their conditions stabilized and acute symptoms receded. Then we shifted to community-based care when the Michigan legislature passed Public Act 258 in 1971. And this statute, which is properly known as the Mental Health Code, was a tipping point for the conversion from an institutional care system to a community-based treatment and support model. Then we accelerated the change into new directions. And I want to just briefly outline what some of those were leading up to where we are today. What is important about that is that between 1991 and to 1996, in accordance with the Michigan Mental Health Code, a very important entry into the statute, which gave the Department of Mental Health, now the Michigan Department of Health and Human Services, general powers and duties to do all the following. And I want to read these. In section B of the code, 330B of the code, administer the provision of Chapter 2 so as to promote and maintain an adequate and appropriate system of community mental health services programs throughout the state, which we have 46 community mental health programs in the state today, and also we have 10 prepaid inpatient health plans. In the administration of Chapter 2, it shall be, and this is important, it shall be the objective of the department to shift primary responsibilities for the direct delivery of public mental health services from the state to a community mental health services program whenever the community mental health services program have demonstrated a willingness and capacity to provide an adequate and appropriate system of mental health services for the citizens of that service area. So over the last 50 or 60 years, the public community mental health system has taken on that task of providing local community-based services for people that were involved in the transition from the institutional era. And what I mean by that, by the mid-1950s, there were more than 559,000 individuals in publicly operated psychiatric hospitals across the United States. In that same period, over 20,000 Michigan residents with mental illnesses were residing in state and county-operated psychiatric facilities. And in addition to that, there were centers for people with what we now regard as intellectual and developmental disabilities were also in state-operated centers for those individuals with those disabilities. Then a change took place very quickly along the new direction between 1991 and 2002, when the state closed 7 state psychiatric hospitals for adults with serious mental illnesses and 5 psychiatric hospitals for children with serious emotional disturbances. And I believe we have only 1 state hospital that's left for children, for youth and children, and that's Hawthorne Center in Northfield, Michigan. This was also followed later with the closure of all state-operated centers for persons with intellectual and developmental disabilities. Then in 1998, which was a major change to the public mental health system, Michigan was among the first state in the country to establish the managed Medicaid mental health and substance abuse specialty services, supports and services program. So Michigan entered into what we call a carve-out arrangement with the public community mental health system to implement its managed care system, which started in 1998 and it continues today. Michigan was also the first state to combine specialist services for persons with intellectual and developmental disabilities into its managed care plan. So Michigan really led the country in a very unique managed care approach to providing services for people in community-based or in community mental health services programs throughout the state. What is of notice here and over the years, and I've been in this system for many, many years, is that almost every year, it's sort of curious, is that people are saying, asking the question, is the mental health system broken? So my answer to you today is that no, it is not broken, but the mental health system has unlimited need with limited resources. What I mean by that is that the various mental health commissions, and I was with the Governor Granholm's Mental Health Commission, and then there were subsequent commissions that were organized. And all of these speak about the need to transform the public mental health system, but interestingly enough, never put forward any ideas for solving the problem of unlimited and limited resources. None of the commissions recommended increased funding for the public community mental health system. So transformation, what does that really mean? Well, I'm just going to take a few minutes in giving you what I believe that it means. The main focus and purpose of county-sponsored community mental health services programs, which are unique in Michigan, by the way, that CMHs or CMHSPs are not simply providers of mental health services. We are also managers of public policy articulated by statutes, rules, decisions, directives, guidelines, statements, practice models. But more importantly, we are charged with implementing and balancing significant, sensitive, and sometimes conflicting elements of public policy. Perhaps that contributes to the whole notion or the question that arises every year that the public mental health system is broken. Transformation also means, in my mind, is that the main focus and purpose of county-sponsored community mental health services programs, I believe that we should be regarded as champions of freedom and justice. In fact, that has been articulated by the Michigan Department of Community Health when I was with the department. The most significant public policy development in the past 40 years has been the effort to eliminate unjustified and unnecessary segregation, isolation, and confinement of disabled individuals. And now we have taken that a step further. We don't refer to people as disabled. We refer to them now as having abilities. And I think that's very important because that's part of the transformation that I'm very proud of that our system is moving forward with. The affirmative obligation on publicly funded programs to promote community integration and inclusion of people with abilities, not disabled individuals, have been accentuated over the last several years by the Supreme Court's Olmstead decision. Moving forward, the budget presentation that was provided to you by the governor, we fully support. And we recommend the budget that the governor has recommended. I want to emphasize that I'm very excited about the governor's executive recommendation for $106 million for certified community behavioral health clinics. I listened to and I saw the presentation that was provided to the Michigan Legislature by the Michigan Department of Health and Human Services, which covered various initiatives, including the statement of serving 166,000 adults, 71,000 children, 62,500 adults and children in certified community behavioral health clinics, and 1,600 adults and children in behavioral health homes. But very little was actually expressed or talked about these innovative initiatives, such as opioid health homes, substance use disorder health homes, behavioral health homes, and of course, certified community behavioral health clinics. I want to mention before closing here that what I'm very proud of is that through a bipartisan agreement, which was led by Senator Debbie Stabenow and Senator Roy Blunt, through the Excellence in Mental Health and Addiction Treatment Act, which became law in 2014, created certified community behavioral health clinics throughout the country. And those are sprouting up and expanding very rapidly throughout the country. And also, hopefully, we can get those expanded in Michigan. This is part of the public system and part of the national focus on transforming the mental health system. So the Certified Community Behavioral Health Clinic Integrated Services of Kalamazoo is one of the demonstration sites in Michigan. And what I'm most proud of here is that, and I've always advocated that priorities should go to, for the public system, we should serve people that are in most of need, and priorities for people with the most severe forms of mental illnesses, intellectual and developmental disabilities, substance use disorder, and also children and youth with serious emotional disturbances. However, the Certified Community Behavioral Health Clinic has expanded that definition to serve persons with any mental health diagnosis, meaning that now we can serve people in our demonstration sites, people with mild or moderate mental health conditions. There are 9 required services, and I'm going to I'm not going to go through all of those, but I'm going to mention those, which includes crisis services, screening, assessment, and diagnosis and risk assessment, outpatient primary care screening and monitoring, treatment planning, outpatient mental health and substance use services, targeted case management, peer and family support and counselor services, psychiatric rehabilitation services, community-based mental health care for veterans. Now, these are the federal requirements of certified community behavioral health clinics. But in Michigan, the public community mental health system provides far more than these 9 services. We are responsible for specialized residential services, which are pretty much known as group home services. We also provide and do pre-admission screening for inpatient psychiatric services, including those services that are operated directly by the state of Michigan. And also there's a change in funding for certified community behavioral health clinics. In addition to the specialty services, the managed care capitation payments, which we've enjoyed since 1998, now we're getting on top of that for our demonstration sites. We're getting a layer on top of that, what is called the prospective payment system, one for per day, for daily visits for eligible persons that are enrolled in our community mental health, our community certified community behavioral health clinics. I want to end here by, just for your information, and you may know this, but it wasn't mentioned in the Michigan Department of Health and Human Services presentation, but there are 13 certified community behavioral health clinics in Michigan, which include Community Mental Health Authority of Clinton, Eaton, and Ingham, CEI, Community Network Services, Eastern Seals of Michigan Incorporated, Health West, Integrated Services of Kalamazoo, the organization that I'm affiliated with, Macomb County Community Mental Health, Right Door for Hope Wellness and Recovery, Saginaw County Community Mental Health Authority, St. Clair County Community Mental Health, Community Mental Health Services of St. Joseph County, the Guidance Center, Washtenaw County Community Mental Health, and West Michigan Community Mental Health. And in addition to those, there are various SAMHSA, Substance Abuse Mental Health Services Administration grantees that have entered into the programs and services for certified community mental health clinics. I have provided much more information in the presentation that I've already forwarded to you. I'm open to questions that you might have. So thank you for this opportunity to speak before you.
Thank you so much, Jeff. We really appreciate your wealth of knowledge and many years of service in our behavioral health area. Before we get to questions, we're going to have Chip Johnston come next, and then Bill Ward, and then we'll open it up for questions for the 3 of you. Chip, I believe you're online.
Yes, thank you for this opportunity. Thank you, Chair and Committee. And following up from Jeff's overview is awesome. Nice job, Jeff. It's a nice springboard for me and makes it real easy. I look up to Jeff. He's been around, and just so you know, I've been in the system for 37 years, from direct care worker to the last 16 as CEO. And I am from a rural community in Manistee and Benzie counties, and we go by Central Wellness Network. And so I wanted to talk about the role of the CMH and particularly in the rural communities, as frankly, we're really the only game in town. And it just isn't economically viable for private enterprise to generally set up shop. So as a result of that, our agency throughout the years has taken on many roles, including serving folks that are beyond our statutory requirement, such as contracts with TRICARE for veterans, and a sundry of other things, including providing substance use services. One of the things that, because we are rural in nature, is we partner with other community entities and public organizations, and primarily one of those to increase access to CMH and mental health services is our partnership with the school systems. For over 35 years, we've had prevention workers in the elementary grades, and we are now all the way to the high school and middle school level with all of our school districts in my two-county area of Manistee and Benzie. The total population, by the way, is only 43,000 between the two counties, which is approximately the size of Rhode Island. So we're pretty spread out. And if you're not familiar, we're tucked up next to the Sleepy Bear Dunes and north of Ludington. So we're west of Traverse City. And so, these collaboratives have led to natural working relationships, primarily, like I said, with the schools and the law enforcement. And because of those relationships, we have a lot of trust and communication back and forth. And one of the programs that Jeff mentioned is the behavioral health home, which we were one of the pilot sites in 2014 and continue to this day. And it has moved into the Upper Peninsula and to many of the southern counties. But the core idea of that emanated from our collaboratives in the schools, et cetera, in the attempt to reduce inpatient admissions and to put more money into prevention and collaboratives because it's so difficult for us to obtain professional level staff, particularly psychiatrists and MSW therapist level social workers. And so because of that, we're able to minimize the impact of folks trying to access those services by getting at them earlier. And what's really nice with the behavioral health home program is because of the funding model, we're able to be flexible. It's based on a case rate we get for everyone that's enrolled that's Medicaid, has to be Medicaid. We are then able to take that and coordinate the care, not only between the public entities now, but we're now working with the primary care physicians to try to minimize their access to higher cost medical expenses. And basically, we have weekly huddles with primary care to discuss high flyers, and they are based on the primary care model, where we spend no more than 15 minutes talking about an individual case. What are you going to do? What are we going to do? Boom, go. And so we really focus on those issues. And at the table for the behavioral health home are the emergency room, the primary care docs, and thank goodness for technology and any, the fiber optics efforts, trying to bring it to the rural communities. It allows us to have this format. The fact that I'm even talking to you today is leaps and bounds from what it was and some of the struggles. In fact, just 2 years ago, one of my schools finally got high-speed internet. They were on dial-up until 2 years ago. So use of this technology, use of the behavioral health home to slowly ramp up and to develop resources for those clients and the people that we serve, not only for our priority population, but for also the mild moderate, if you will, has been just a huge boon to the community. Out of that also came because we have difficulties obtaining substance use providers. And one of my smaller communities, Benzie County, experienced 4 opioid deaths within a year, which is a huge number of folks when really you only have 18,000 people. We launched into becoming an opioid health home and tied that into a Medicaid assisted treatment clinic. So the awesome thing about CMHs is they're allowed to be flexible and adapt to their community needs and to join with partnerships to foster relationships and to maximize resources for the client. So how it looks when someone comes to our service and looking for mental health services, they call us first naturally because we're it. And we base the assessment on client identified needs and then funnel them into the appropriate access intake based on what they're telling us. And then we work with their insurer or whatever to maximize their benefit and do warm handoffs and the like. And so the behavioral health home team and the opioid health home team, when someone comes in that's identified as that, we can use those funds to tailor for the Medicaid and then look at using what's called an RN case manager to connect the dots to all the different things that that individual needs that's beyond our expertise, and to ensure that they get the services they need, not only for their physical health, but to improve their mental health. There is also then associated with that a peer support who can also then work with that person on their, having experiences and working on their level as to the hurdles and walking them through trying to navigate healthcare. I don't know about you. Generally, when I get into a healthcare issue, I get frustrated myself, and I actually refer to my wife, and she fixes it for me. So that's, I liken it to that. I know how this works. Here's who you call, and so forth. And I always say that our healthcare partners, including the health plans, have been really good in identifying folks who really need the services and making sure that we connect. Some vignettes. For example, we've had someone who's come in, had a really bad leg infection. We worked with the primary care person provider to get them into a specialist. And had we not done that, the person probably would have had sepsis or had leg amputation. Another example is a client with very high diabetes scores, got him down to acceptable levels, is now doing well. Working through our nurse, we identified chronic kidney disease, got him in to see a specialist, and put them on medications, and they have the disease is essentially prevented and eliminated. And so we're able to then work on the issues that are associated with that. Another example is one of a provider, the CMH out of Petoskey, North Country, had an individual whose mouth was very sore, got him in to see, worked with them to get him on medication, and I'm sorry, on to Medicaid, and then to the U of M hospital for a specialist, an oral surgeon, to have it taken care of. And so since then, they've gained weight and are healthier again. So it's the behavioral health home and the opioid health home are sort of conduits and translators between what we know and what they know. Other common items such as thyroid disease, I myself have had that, and that can manifest itself as a mental illness. So the ability to connect physical health and behavioral health together has just been a wonderful thing. The financing model for behavioral health is, like I said, is a case rate that allows us to, it puts us at full risk and allows us to reinvest any savings into the program for consumer supports and to develop professional staff over time. And so from a rural perspective, that's very nice to kind of be planful and mindful about what's coming and to assure that we have the resources available, because there's nothing in my mind worse than promising something to your community and then not being able to deliver. So with that, I will wrap up and wait for questions later. Thank you for your time.
Thank you, Chip. That is so valuable to hear about the rural perspective. So thank you for that. We'll move to Bill Ward, CEO of Network 180 in Kent County.
I thank Chip and Jeff for everything that they've said so far, so I'm going to keep my comments brief to leave time for questions, and I'm going to focus on one area of behavioral health. Good morning, Madam Chair, Representative Committee members. Thank you for having me here today to speak about the great work that's currently being done in Kent County for the area of behavioral health crisis services. My name is Bill Ward, and I'm the Executive Director at Network 180. That is Kent County's Community Mental Health Authority. Over the past several years, Kent County has undertaken a community planning process to create a comprehensive crisis continuum for all Kent County residents, regardless of insurance status. Typically, CMH crisis services are only available to populations served by Medicaid, Medicaid expansion, or the uninsured. Network 180 aims to create a no wrong door, regardless of insurance status. The planning process was completed after years of work done by the Population Health Consortium, which was co-chaired by the chairman of 42 North Partners, the Kent County Administrator, the CEOs of Corewell Health, Trinity West, U of M West, Mary Free Bed, Forest View Hospital, Pine Rest Community Christian Mental Health Services, Hope Network, and Network 180. We came up with 5 major initiatives. The first was the establishment of a behavioral health crisis center in downtown Grand Rapids, located on Trinity Health's campus near St. Mary's Hospital, operated by Network 180 in conjunction with Trinity Health St. Mary's. The facility is under construction right now and set to open in late 2023. When completed, this 24/7 crisis stabilization unit will allow for voluntary and involuntary placement of individuals regardless of insurance status, and will allow for secure drop-off for law enforcement and EMS, thus diverting the individual from inappropriate use of an emergency room and unnecessary booking into the county jail. Second, the creation of enhanced mobile crisis response throughout the county. Currently, we have 2 teams that operate at limited hours for both adults and children. This will create a 24/7 operation, which will cover, again, the entire county, regardless of insurance status. Third, an enhancement of a 24/7 call center integrated with 988 and with the goal to integrate with the 2 dispatch centers in Kent County, GRPDs and the Kent County Sheriff's Department. Fourth, the enhancement of a sobering center in downtown Grand Rapids, located at the homeless shelter operated by Mel Trotter Ministries, which is currently open and was implemented last year. And fifth, the creation of a peer respite center for individuals to de-escalate from a crisis in a non-clinical setting operated by individuals with lived experience. That facility is also already open. This represents a $22 million investment over the next 2 years for Kent County. We expect every one of these initiatives to be fully operational within the next 2 years. And we are very grateful that the legislator provided $5 million for startup construction on all these initiatives. And with that, I will close and open up for any questions.
Thank you so much, Bill. Appreciate that. We have time for a couple quick questions. First, Rep. Green.
Thank you, Madam Chair, and thank you everybody zoomed in and for your presentation. A couple questions that are the same question. I'll say it that way. Regarding number 1 on your appropriations key issues, I remember a day not too long ago when it was debated inside of the legislature, a 25-cent raise for direct care workers. How can we delete or modify the model of funding that requires the legislative body of the House and the Senate to vote on the pay raises of your, to put it blunt, no disrespect, but we're voting on the pay raises of your entry-level workers. I don't think we vote on the pay raises of your administrative staff. And so along with that is, if we assume there's no money for a $4 wage increase, if that's the assumption, what else can we do to allow you to save money in areas so that you can pay your employees better? So it's sort of, you understand the duplicity of that question, but it's the same question.
I don't know if Jeff's on, he wants to take that. He's the more seasoned one, but
I don't know if I completely understand the question. Would you just repeat that question because it was pretty loaded?
Yeah, how can we get away from the model of the legislative body of 148 people across the state voting on a pay raise for your entry-level workers? And then in that same respect is, if we say there's no money, but we can't give a raise this year, what else can we do to cut your overhead so that you can give your employees a raise without asking the legislature to give your employees a raise?
Well, I'll make a quick response to that. I think is I can give probably more than one response to it. But one of the areas, and I think that Bill Ward was just talking about that, is our capital improvements. You know, we don't, community mental health services programs do not get any kind of appropriation for capital improvements. And we have to either get local funding for that. Some community mental health services programs have gone to the counties for money or foundation dollars. I think that some of the savings that can be realized if there was a separate capital outlay for at least the 46 community mental health services programs in the state. Again, you know, the expectation is that we have to meet unmet need. And the question that you're asking is, when do we meet that unmet need? Because it grows and grows and grows. You can see it on the news media. You can see it on various outlets. The need for mental health services, but yet the dollars for that, and I'm not just talking about Michigan, but nationwide, does not keep up with inflation. It does not keep up with many other kinds of costs that we have to bear. The beauty of the public system in Michigan is that any unspent dollar goes right back to the state. So I think that there can be some other kinds of funding arrangements where those dollars or more of those dollars can be kept. For example, the risk reserve for prepaid inpatient health plans are set at 7.5%, I believe. That was set when I was with the Michigan Department of Community Health. There's no magic number on that. And so to be able to put aside dollars for when there's overages or the need to fund or to give staff raises, that could be an area that could be improved, is to increase that risk corridor. The other area is that, again, with capital outlay, because we have to come up with the dollars, we use our depreciation to, I guess, in an indirect way to fund it. But when we need to have facilities, we have to sort of rob Peter to pay Paul to try to manage. And for smaller boards in rural areas, I would think that it's even more difficult to raise the kind of capital needed for modern equipment, for expansion of staff, and just the quality of facilities. So I guess I'm giving you more than a mouthful, but I think those are some of the areas that could be considered and added to future budgets.
Yeah, Jeff, if I may, I have a follow-up to that. I thank you for speaking about the rural issue. The DCW pass-through notion, for us, it's actually harder to attract professional staff. And so by earmarking it to that particular staff classification, it makes it increasingly difficult for me to attract other professional staff, nurses, social workers, even bachelor's level folks. The nearest college for me is Ferris State, which is over 2 hours away. So I don't have much opportunity for interns, that sort of thing. And it's even more difficult if you're in the Western UP, for example. So, the ability to be flexible, and maybe just, my thought would be to just simply have that part of our base funding and quote unquote, let the market do the work. And have us take care of business. The other thing that's very painful, if you will, for a rural board, the canary in the coal mine, is incessant audits when we have to, because we're already accredited nationally in order to bill third-party insurance through JACO, CARF, COA, whatever accrediting body you may have, we have an expense for that, but then we have to then incur audits from MDHHS and our regional entities, who are in turn also audited by the department for a variety of things. And it would be very beneficial, I believe, particularly for my shop and others, I'm guessing around the state, that if you had an accreditation that was in the areas that was in your contract with the department, which are pretty standard nowadays, that's good. Let it be. And to have those reports, submitted to the legislature and so forth, to kind of, for quality, if you're concerned about that. So those are two of my thoughts on that question.
Okay, thank you, gentlemen, for being with us this morning and giving us your perspectives. We're moving on to Laura Pell, Executive Vice President for the Michigan Health and Hospital Association.
While they're pulling up their slides, thank you, everyone, Madam Chair and other committee members for having us here today. Thank you. And I am Laura Oppel from the Michigan Health and Hospital Association. I'm an executive vice president there. Joining me is my colleague, Lauren Lapine. Lauren is one of our senior directors. She's also in the doctoral program in public health. And she is our staff leader on behavioral health issues. So with that, let's move quickly into a tiny little bit about who is the MHA. You'll see up here we have 162 member hospitals. You might think to yourself, I didn't think we had that many hospitals in Michigan. We don't have that many acute care hospitals. What you think of, what I think of as a hospital with an emergency department is a much smaller number, as it says up there, about 129. And so we count in our membership inpatient rehabilitation hospitals, long-term acute care hospitals, and of course, inpatient psychiatric hospitals. But let me note that some of the inpatient psychiatric care that is offered at, outside of state psychiatric hospitals is in the acute care setting. So for example, the hospital in Elma has 5 floors. 4 floors are what all of us think of as med-surg. The top floor is all for psych. So moving on, I wanted to share with you this information about the desperate staff shortage that we continue to face. We just got done doing this member survey on our workforce shortage. Part of what's, you might say, well, exactly what does workforce shortage mean in terms of the monetary challenges? Last year in MHA membership, I am not talking about nursing homes, I'm not talking about the state's responsibilities. For example, in the prison system, they have nurses. But just MHA alone, the cost of temporary staff, primarily nurses, was an extra $1 billion. So it was real money last year. I want to mention that we are absolutely thrilled that you all were part of the Appropriations Committee action on appropriating another $75 million to help offset that very large number. So back to my workforce survey here, you can see that we have thousands of people that we need to employ in the healthcare system, 8,500 nurses. We believe that we have about 62,000 nurses working in hospitals now, and we need another 8,500. We have 8,500 openings. I want to be clear, this number does not include anybody else. It's not nursing homes, it's not state psych hospitals, it's not anybody in a primary care setting. This is just us. So I'm sure that that number, 8,500, is much larger. We also, on this survey, didn't ask about the physician shortfall. Earlier, the gentleman talked about the shortages that we have in behavioral health services. I used to say we have no child psychiatrists in the Upper Peninsula. That has changed. We have one. We also have dozens, and I mean dozens, of counties in the Lower Peninsula where there is no child psychiatrist with an address in that county. So they might be practicing somewhere or living somewhere else and practicing in that county, but probably, I think, a total of 60 counties have no child psychiatrist. One of the things about boarding patients, I appreciate Network at 180 and bringing a crisis stabilization unit online. We are all looking forward to what improvement that might be for what happens in hospital emergency departments, but we are still very worried about what's going on with us, and worried enough that we frequently have our hospitals connect with us, and we are lucky to connect with the department who responds quickly to say, this person has been here 22 days, this person has been here 22 weeks, waiting in the ED for inpatient psychiatric services. And, but we needed to get our hands around this on some of the data. So I will be honest, completely copied the Massachusetts Hospital Association and started doing this. And every week now we are asking our entire membership to report to us, and I want to make it clear, this is a snapshot. This is not a scientific survey, but every week we ask them, will you please on Monday morning or Tuesday afternoon, very close to the early part of the week, stand up and look around your ED and tell me who's waiting. And this week, we had 36 hospitals report, which is 25% of our membership. And you can see we had 68 people who were already determined to need psychiatric inpatient care, and they're waiting for psychiatric inpatient care. On my next slide here, I can show you that we had a number of, and it's covered up by where it says talking, but at N up there is 25. There were 25 people waiting for their psychiatric evaluation. Now, this doesn't mean that they've been waiting overly long or that they've been waiting inappropriately. It just means that we probably, if we didn't think they needed inpatient psych, we wouldn't be asking them to wait. So my guess is those 25 people are also destined for inpatient psychiatric care. So nearly 100 people are waiting in Michigan hospitals in 25% of Michigan hospitals. And that doesn't include a couple other numbers here I have about people waiting on a med-surg floor because they have medical conditions before they can get to their psych condition, or people that are medically cleared and still in the med-surg floor. So all of these slides will be available for you. I want to move on quickly to talking about our appropriations. Using our appropriation from FY23, we have the opportunity to start some new programming for pediatrics patients in particular. There was $50 million appropriated, and the MHA is working on getting that out the door as fast as possible, and Lauren has been working on the design of exactly how that will happen and the application process. And then I also wanted to mention that while we understand that a lot of people are waiting probably because we have a small number of beds, of state psychiatric beds at the state hospitals, Hawthorne, Walter Reuther, Kalamazoo, et cetera. We are working every other week. We meet with our department colleagues, and it's a great opportunity to discuss what's going on and how we can resolve some of these what feel like intractable problems. The CMHs join us in that conversation, their leadership there. I applaud everyone. We have been doing this since August, and we're still sticking it out because I'm not sure how many things we've actually solved, but we are dedicated to working at it. So moving on to FY24, I just wanted to show you this. We have a general fund ask in the FY24 budget of $86 million because of matching money. That generates $450 million for the MHA membership, which include, like I said, is very broad. In particular, we're asking for just over $8 million of that to support an increase in inpatient psychiatric rates, not for everybody, just for those cases that are high acuity. And the easiest way for me to explain high acuity is, for someone who is a high acuity patient, they might need one caregiver to the patient. They might need two caregivers to the patient. It's a very expensive way to provide care. And so I want to close by saying, I hope you will consider this entire request, not just the part for inpatient psych. And, certainly we appreciate what the governor's proposal invested in, and I understand there are many needs across our state. But I hope you will consider this small investment for our most vulnerable residents among your highest priorities. So with that, I'm going to close and invite you to, whether it's today or later, please reach out to us at any time with questions or if there's more information you seek. Thank you, Madam Chair.
Okay, we're gonna take 2 quick questions. Oh, that's okay. Okay. Rep. Bolin has a question.
Thank you, Madam Chair. Thank you very much for your presentation. I have a question as it relates to the patient that comes into the hospital, and they may have a medical condition, but their entry may be a psychiatric one, and they're kind of on hold, if you will. And whose responsibility is that patient? Is it the psych unit or the medical unit?
Yes. Yeah, we have a challenge with that because in the managed care, generally seeing people as being in managed care, you'd be like, well, I manage their entire care. And up to the point of moderate illness, our Medicaid managed care companies should be thinking of handling that. Especially, I often use the example of, let's say that someone has severe postpartum depression, but also maybe some complex needs related to a C-section or something. And that is exactly where, like, let's say that there was maybe an infection starting, we got that under control, but this person still needs inpatient psychiatric care. Our system, as it stands, is not designed in a good way to try and figure out how to parse out those payments. I know the department is working on this. We've talked that the health plans have tried to help our members with this. It hasn't happened yet, but not for anyone's lack of trying. And I know the department is currently working on yet an actual policy related to this, and we want to be engaged with that as well.
Thank you. I would like to be engaged with that as well. I think it's extremely important. I don't think the patient, potentially the patient is placed at risk for medical conditions, and nobody wants to take, so it may be mild or something they can hold off on other medical prescriptions maybe, and then they're left. So I do think it is an area that we need to explore.
Definitely getting attention, and it has been the definition of an intractable problem. Thank you.
Thank you so much to the Health and Hospital Association. They are a wealth of knowledge, and they are living this every day. So please feel free to reach out to them if you have further follow-up. Thank you so much, Laura, for being here. And last, we will call up the department. We have Dr. George Mello, Senior Deputy Director for State Hospital Administration, and Amy Epke, Senior Deputy Director for Financial Operations. So it's 11:25. I think if you could try and do this in 10 minutes, or there's always opportunity to come back. But if you can do it, that'd be great.
Good morning, and absolutely we'll keep it to 10 minutes. So thank you again for the opportunity to be here. As mentioned, I'm Amy Epke, Senior Deputy Director for Financial Operations at DHHS. And today I have with me Dr. George Mellows, who oversees our state hospitals. In a minute, I'm going to go ahead and turn it over to him. One thing I wanted to mention, as you've heard from previous meetings that we've had, we have a number of initiatives in the 2024 budget. You'll see our ask for state hospitals administration is pretty small. It's a small ask, but it's an important ask. And part of the reason it is a small ask this time is we also have current funding in the 2023 budget of $325 million for a new psych hospital. And I'll go ahead and turn it over to Dr. Mellows to talk a little bit more about some of the efforts at the state hospital at this point.
Good morning, everyone. Michigan's public state psychiatric hospitals, we have 5 of them. Caro Center, Kalamazoo, and Walter Reuther are the 3 adult facilities. Caro Center serving eastern side of Lower Peninsula and the Upper Peninsula. Kalamazoo, western Lower Peninsula. Walter Reuther, the southeastern Michigan area. And then we have Hawthorne Center that serves the entire state, which is a children's psychiatric facility. And then the Center for Forensic Psychiatry in Saline, which also serves the entire state. The 3 adult hospitals mentioned just now, admit patients who come through the probate court process, court ordered into the facilities with petitions and certificates, and then also incompetent to stand trial restoration process. The Center for Forensic Psychiatry only the restoration process orders, and then of course kids come through a probate process also, all voluntary admissions. Go ahead. Out of our 5 hospitals, only one was built in this century. That is the Center for Forensic Psychiatry in Saline. Walter Reuther, Hawthorne Center were both built after World War II. Caro was built in 1914, and the Kalamazoo Psychiatric Hospital in the 1800s, early 1900s. We have worked very hard with the governor's office and the legislature over the years to describe how it costs the department millions of dollars to sustain these aging facilities, and we're able to secure monies in 2020 to build a new psychiatric hospital, 100 beds in Caro, which will we'll get the keys in June and finally be able to move patients in. We're really excited about that, and we'll be having an open house in May. It's on a 27-acre campus, and what's been amazing working with the design team and the construction team during the pandemic and all the supply chain issues, they have these amazing algorithms and have been able to forecast supply chain issues, and we stayed on target and under budget in building that facility. In fiscal 23, $325 million out of ARPA funds came our way, the department, to replace Walter Reuther and Hawthorne, and I am not kidding when I say it's millions of dollars a year to maintain both of those facilities. They're aging post-World War II facilities and are not in any way modern behavioral health care entities. We're in the process of identifying a site for this combination facility. There will be basically 2 separate hospitals, one for kids, one for adults, joined centrally by an administration. We'll be able to get a lot of efficiencies out of that administratively and clinically. Construction must commence later this year, and the anticipated completion is in 2026. So I think all of you are aware of our wait lists, and they're infamous, unfortunately, and they're reflected all over the country, and in fact here not as bad as in other states. We right now have a total on the wait list of about 400 people. That's 250 to 60 IST, incompetent to stand trial individuals who've been ordered to restoration to the state hospitals, and then the rest are probate process patients. In order to abate some of that wait list, we work very closely with our partners in community services, meaning the PIHPs and CMHs, in developing a program called Intensive Community Transition Services, piloted out of the state hospitals 3 years ago, and are now expanding that into the community so that we can take some of the people who are actually on that wait list and divert them into hospital level of care entities in the community. This hopefully will also help with some of the emergency room pressure and aftercare home facilities that are running into trouble with patients. We are also expanding behavioral health care access using a Center for Medicaid Services reimbursement mechanism called psychiatric residential treatment facilities, and are deeply in the process of drafting CMS policy for a potential state plan amendment and going live with these entities for people 21 and under in the state of Michigan. As you know, the state psychiatric hospitals have, like all medical facilities, psychiatric facilities, private sector and public across the country, have grim resource issues, both professional, meaning nurses, doctors, social workers, psychologists, and most importantly, direct care staff. Since about halfway through the pandemic, people stopped applying for jobs, particularly direct care staff in facilities, and consequently we have had to reduce our census from about 750 at this point to 600. It is certainly helpful for the workforce. The amount of overtime has gone down and the burnout has improved, and we have the rate of people leaving has slackened, and we're just now seeing an uptick in applications again, and I'm looking forward to that increasing. We've already gone over the state hospital wait list. I think we can skip this slide because I know our time is limited. We're very excited that in the governor's budget, we were approved for occupational health clinics. The facilities do not have occupational health clinics, and there are a number of reasons for why that has not ever been in place. The facilities are legacy facilities and they predate licensing. Consequently, we have always internally managed occupational health. That is no longer possible with the exigencies of data entry associated with infectious disease, and then most importantly, workplace violence. Standards from Joint Commission, MIOSHA, and CMS are quite strict about this at this point, and we are delighted that we have this opportunity to open up occupational health clinics to improve health metrics and operationalize the workplace safety standards that we must. Moving forward, CARO will be completed this year. We're in the design, construction, planning phase for the new Southeast Michigan Psychiatric Hospital. It'll be a 260-bed hospital. And then the establishment of occupational health clinics. We will continue to work very closely with the community sector in the development of psychiatric residential treatment facilities and other community-based programs. And we are finally innovating in regard to the incompetent to stand trial in custody individuals who have been ordered to restoration. We've developed a community supports restoration clinic with quotation marks around it, working with the county jails across the state to help them appropriately treat while people are in custody for the psychiatric illnesses that they have, both medication and behavioral health care.
And with that, we can go ahead and take any questions that you may have.
Okay, thank you so much, Dr. Mellos and Amy, for your presentation. Sorry, it was a bit rushed today. I'm just going to kick off the first question. So, given that we are building, CARO's almost done, we're building a new facility, how well situated will the state be bed-wise when those facilities are completed?
That's a really good question that we're struggling with. I talked to the superintendents of state hospitals across the nation, and it's a really good question, and we don't know. I think that right now, with a wait list of 400, it appears like we need 400 more beds, but that is a simple reduction. We're also working very closely with the community sector to develop hospital-like resources in the community through the psychiatric residential treatment state plan proposed amendment, and then also through the intensive community transition services program that we've developed. We're hoping to be able to move a number of people off that wait list. Predictions are hard to make, though, because there are so many variables involved. The community sector is struggling with the resource issues that we're also struggling with.
So do you think if we build on that and those community resources and the psychiatric residential treatment facilities, because obviously, I mean, there's a lot of talk, of course, about where our public mental health has gone the last 30 years and why it's gone that way. But part of the impetus was the court case that we don't want to keep people, in a facility. So do you see those as really filling that role that didn't exist for the people that really need those intense services? Is that where we get those services that those people really need to not be really held in a state psychiatric situation?
The community-based resources, essentially hospitals without walls, meaning that the hospital level of care, however, in the community is the direction that almost all states are going. It's not fast enough. We have many people, 400 people waiting to get into our beds practically at this point. Many people in ERs waiting to get into private sector psychiatric facilities. And there are a number of variables that are behind that. One of the biggest variables, again, is staffing resources. It's not money. We're practically flush with money in the state hospitals. We just can't hire people. No one has applied. We've gone months and months at a number of facilities with no direct care staff applying.
Well, there's a fair number of dollars in the budget to try to fill that gap on the behavioral health side. I'm going to call on Rep. Boland. She had a question.
Thank you, Madam Chair. Thank you so much for being here and for your work. My question is specifically about the Walter Reuther and Hawthorne. I mean, I think it's long overdue. I've been advocating for a new hospital. I think that having a better environment, safer environment, even for the workers, will help us maybe a bit with that workforce. But I wonder what the status is with the site selection.
That's a really good question, and I wish I could answer you absolutely and directly. We are down to a couple of sites in terms of site selection, and they are solidly in southeastern Michigan, meaning Wayne and or Washtenaw, Livingston counties.
Thank you, because we have a lot of property there at Hawthorne, and I would be advocating for citing that there because we have the land. We don't have to, go through that process. But I look forward to the progress. Thank you.
All right, seeing no further questions, I thank everyone for your presentations today and thank you for your work. Representative Price moves to excuse absent members. Hearing no objection, absent members are excused. Seeing no further business, this meeting is adjourned.